Good afternoon. My name is Jean-Baptiste, and I'm here to present on my EBM article titled Isosorbide Mononitrate and Heart Failure with Preserved Ejection Fraction. First, let me discuss what exactly is heart failure. Heart failure is a condition in which the heart is no longer able to pump oxygen-rich blood to the rest of the body efficiently. So, when your vital organs aren't receiving oxygen-rich blood, you can have organ damage. So kidney failure, strokes, or heart attacks, MIs. So isosorbide mononitrate is a drug used to vasodilate or widen the blood vessels in these patients, and is typically used for patients with ACS, acute coronary syndrome, in which they have chest pains. So the isosorbide nitrate is used to relieve the chest pain. So in this particular experiment, which I found on the New England Journal of Medicine, and which was sponsored by the National Heart, Lung, and Blood Institute. So let me first go into the background. Approximately half of patients with heart failure have preserved ejection fraction. Exercise intolerance is a cardinal feature of this syndrome and perpetuates sedentary behavior, meaning patients with heart failure, they can lead to a sedentary lifestyle, which isn't good in our patients, because we need our patients to at least get some type of exercise. That includes biking, swimming, some type of exercise to help relieve some of the symptoms. So, in early studies in patients with heart failure with reduced ejection fraction, long-acting nitrates improve activity tolerance. So the whole purpose of this study was to see if isosorbide mononitrate would increase exercise tolerance within these patients. So let me go through the objective. The goal of the trial was to evaluate the treatment with a long-acting nitrate compared with a placebo among patients with heart failure with preserved ejection fraction. As I stated earlier, funding was by the National Heart, Lung, and Blood Institute. So the trial design, which was a multi-center, randomized, double-blinded, placebo-controlled crossover test. Excuse me. The study was done at various institutes, which the data was all sent to Duke University. So this study was approved and sponsored by the National Heart, Lung, and Blood Institute. The protocol was approved by the Protocol Review Committee of the Institute of Heart Failure and Clinical Research Network and monitored by the network's data and safety monitoring. So the inclusion criteria: ambulatory patients with a diagnosis of heart failure were eligible if they were 50 years of age or older and had heart failure while they were receiving stable medical therapy. Patients were required to have an ejection fraction of 50% or more and objective evidence of heart failure as shown by one or more of the following criteria within 12 months before enrollment. So those criteria include previous hospitalization for heart failure with a radiographic evidence of pulmonary congestion, elevated left ventricular and diastolic pressure at rest, or elevated pulmonary capillary wedge pressure at rest, or exercise greater than or with exercise, and an elevated internal pro-brain nitric peptide, NT-proBNP. It's basically an indicator of heart failure. So patients that were excluded from the study included patients with a systolic blood pressure of less than 110 or a systolic blood pressure greater than 180, or if the patient was previously on isosorbide mononitrate or had an adverse reaction. So patients that had allergies or a severe adverse reaction to isosorbide mononitrate were excluded from this research. So the subjects included humans. So basically, patients were supplied with a belt and outfitted with 2 kinetic activity monitors by the Kirsch Health, and they both contain high sensitivity triaxis accelerometers. Patients were instructed to wear the accelerometers 24 hours per day, except while bathing or swimming. Each accelerometer was matched to a patient by means of serial number and activated at the time it was dispensed, providing time and date stamp data synchronized to the study protocol. The accelerometer measures are expressed as arbitrary accelerometer units. These are stored as 15-minute cumulative accelerated units. The 15 cumulative accelerators were totaled over a 24-hour period to have a daily accelerator unit. So basically, the patients that were part of the study were given a belt, and while they were taking their drug, isosorbide mononitrate 120 milligrams, their exercise activity were measured, and the doctors and clinicians were trying to figure out whether or not the drug improved their exercise tolerance. So, I stated the inclusion criteria, stated the exclusion criteria. So I'll go into the endpoints. The primary endpoint was the daily activity level, quantified as the average daily accelerometer units during the 120 milligram phase, as assessed by patients worn accelerometers. So basically, the patients were given the belt, they were taking the drug, and their daily exercise activity was measured according to the accelerometer. So the doctors took that information, recorded it, and looked to see if the drug isosorbide mononitrate improved their exercise tolerance. The secondary endpoints included hours of activity per day during the 120 milligram phase. That's how much. That's the dosage of the drug and the strength that they were taking. 120 milligram PO of the drug isosorbide mononitrate. So follow-up. So the results based on the program was 12 weeks. It was a randomized trial medication, and the patients will come in every week with the data provided by the accelerometer, which is the belt that they wore, and the scientists or the clinicians or the doctors will take that data and compare it. So the duration, this study took approximately 12 weeks. The population, a total of 110 patients were selected with chronic heart failure, were enrolled at 20 sites in the United States, with 51 patients assigned to receive isosorbide mononitrates first and placebo second, and 59 patients were assigned to receive placebo first and isosorbide mononitrate second. So let me go into basically the demographic of the patients. The mean duration of heart rate was 1.8 years. The mean age of the patients was 69 years. 57% of our patients were women. The majority of the patients were white and obese with controlled blood pressure and multiple coexisting illnesses. Most of the patients were taking multiple cardiovascular medication. So, statistical analysis. In a not statistical analysis, but arms. So, active comparator, isosorbide mononitrate, isosorbide mononitrate with doses up to titration. So, 30 milligrams to start off with, then it was titrated up to 120 milligrams over 4 weeks. So placebo comparator isosorbide mononitrate compared to placebo. The isosorbide mononitrate placebo with dose up to titration, the same 30 milligrams given initially, then titrated up to 120 milligrams per day over 4 weeks. So the statistical analysis. In a crossover design, the researchers estimated that the enrollment of 94 patients would have a power of 80% to detect a minimal, clinically significant difference of 5 points on the clinical summary scores of Kansas City cardiomyopathy questionnaire, and that the enrollment of 60 patients would provide a power of more than 90% to detect minimal clinical significant difference of 43 meters in 6-minute walking distances. 13 estimates derived from reproductivity data with a different accelerometer in 49 elderly sedentary volunteers indicated that the enrollment of 100 patients will provide a power of 90% to detect a relative treatment effect of approximately 2.5 of the baseline measurement. The target enrollment was approximately 100 patients. The analysis was not adjusted for any between group differences at baseline. At two-sided p-value of 0.05 was considered to indicate statistical significance. For this primary endpoint, interactions between treatment effect and number of pre-specified baseline characteristics was assessed. So the results section, the primary endpoint. During the 120 milligram phase, 101 patients during the first period and 91 during the second period has unstable accelerometer data with a median of 16 complete days of accelerometer data. During the first period and 14 complete days during the second period. For the primary endpoint of average accelerometer units during the 120 milligram phase, there was a non-significant trend towards lower activity during the receipt of isosorbide mononitrate than during the receipt of placebos, with a treatment effect of 381 accelerometer units per day. As secondary endpoint, as compared with placebo, there was no significant effects of isosorbide mononitrate on a 6-minute walking distance or post-walk dyspnea score. The clinical summary score on the Kansas City cardiomyopathy questionnaire, the total score of Minnesota living with heart failure questionnaire or the NT-proBNP, which, as I stated earlier, was an indicator of heart failure. Although the treatment difference was not significant, the direction of the numerical effects on quality of life scores and BNP levels were unfavorable for isosorbide mononitrates as compared with placebo. Isosorbide mononitrates decreased blood pressure. Similar proportions of patients indicated that they felt better during the receipt of isosorbide mononitrates was 36%, and patients that received the placebo was 30%, and 33% of the patients had no preference. So while reading this article, I noticed that that they didn't mention any adverse side effects, which I think was the primary weakness of this article. But I looked it up. The most common adverse effect of isosorbide mononitrate is nausea. So the author's conclusion: patients with heart failure and preserved ejection fraction who received isosorbide mononitrate were less active and did not have better quality of life or submaximal exercise capacity than patients who received the placebo, meaning that there were no positive outcomes of this experiment taking long-term isosorbide mononitrate did not improve exercise tolerance. So the major strength of this article was the fact that it was a randomized, double-blinded, placebo-controlled crossover study, in my opinion, which eliminated biases. So basically, in summary, in this article, researchers compared the effects of isosorbide mononitrate or placebo on daily activity in patients with heart failure and preserved ejection fractions. Patients with heart failure and preserved ejection fraction were randomly assigned to a 6-week dose escalation regimen of isosorbide mononitrate from 30 milligrams to 60 milligrams to 120 milligrams once daily, or placebo with subsequent crossover to the other group for 6 weeks. In the group receiving the 120 milligram dose of isosorbide mononitrate as compared with the placebo group, there was a non-significant trend toward lower daily activity and a significant decrease in the hours of activity per day. During all dose regimens, activity in the isosorbide mononitrate group was lower than that in the placebo group. Activity levels decreased progressively and significantly with increased doses of isosorbide mononitrate. The researchers concluded that patients with heart failure and a preserved ejection fraction who received isosorbide mononitrate were less active and did not have better quality of life or submaximal exercise capacity than the patients who received the placebo. So, isosorbide mononitrate had a negative effect on the exercise tolerance. So, my thoughts on this article. I believe this article is relevant to the area of cardiovascular disorders such as chest pain and heart failure. Nitrates are frequently prescribed for patients with heart failure with preserved ejection fraction, for whom exercise intolerance is a common characteristic. But the evidence from this article has suggested that nitrates actually decrease daily activity in heart failure patients. Nitrates are still effective for managing the symptoms of acute coronary syndrome, which is chest pain, but not recommended for heart failure patients as a method to increase daily activity. So that is my presentation. Thank you so much and have a great day.